Great. Thanks so much, Dr. Chow, for the kind introduction there. As Dr. Chow mentioned, my name is Chris Ripplinger. For those who I haven't met yet, I'm a PGY5 cardiology resident at the University of Saskatchewan, and I've been here for the past 2 weeks doing an echo elective. And I'm honored to be able to present at today's echo rounds. I'll be discussing about the topic of mitral valve prolapse and mitral annular disjunction, the title being Mind the Gap. The objectives for today's talk are to review the relevant mitral valve anatomy as it pertains to mitral valve prolapse. We'll discuss the diagnostic criteria, etiologies, echocardiographic features, and management principles of mitral valve prolapse, including some case examples from the past 2 weeks at St. Mike's Hospital. We'll then explore the concept of mitral annular disjunction, short-term MAD, including its echocardiographic appearance and clinical implications, ventricular arrhythmias.
Still on your lab. Yeah, I'm just going to see your echo.
Yeah. Okay. Well, that's much better. Yeah, echo could be better now. All right. So just as an introduction, we're going to talk about a bit of the mitral valve anatomy, as it is important as we get into discussing mitral valve prolapse. So the mitral valve anatomy is a bit complex and involves more than just the mitral valve leaflets. So it includes the mitral valve annulus, which is a saddle-shaped or D-shaped annulus. It contains the mitral leaflets, which consist of the anterior leaflet and the posterior leaflet. We have the subvalvular apparatus, which consists of the chordae tendineae with primary, secondary, and tertiary chords. We have the papillary muscles that sit in the left ventricle, the anterolateral or medial papillary muscles, and then we have the left ventricular wall and left atrium that are components of the mitral valve apparatus. This will become more relevant as we talk about mitral valve prolapse and mitral annular disjunction. Looking a bit closer at the mitral valve leaflets, I know this may be a review for most, but just to set the stage. Here on the left, we have a transthoracic images of a parasternal long axis view at the top left there, where we can see the anterior mitral valve leaflet on the top and the posterior leaflet on the bottom there. And then if we turn to an orthogonal view looking at the short axis, we can see the anterior leaflet on top and the posterior leaflet on the bottom. Breaking down the leaflets into their individual components, looking at the scallops, we can see that the anterior leaflet and posterior leaflets generally have 3 scallops each. And on a transthoracic echocardiogram in the short axis, from left to right, we have A3, A2, A1 on the top, and then P3, P2, and P1 on the bottom there in the posterior leaflet. Now looking at the subvalvular apparatus, talking about the chordae and the papillary muscles. So as I mentioned, regarding the chordae tendineae, we have the primary chords, and their role is they insert right into the leaflet tips. So they help to ensure coaptation and prevent eversion and prevent flail, but they aren't the kind of main load-bearing chords, chordae tendineae. Where we come to the secondary chords, which they insert into the leaflet body. These are the primary load-bearing and mechanical dispersion chords. And then lastly, we have the tertiary chords. These attach to the leaflet base. And then instead of them attaching directly to the papillary muscles, they can attach to the papillary muscles, but then they can also attach directly into the ventricular myocardium. They act as anchors to provide additional structural support. And then again, we have our papillary muscles, posterior medial and anterolateral. The zone of coaptation is an important concept to be familiar with, as it is relevant when we talk about mitral valve prolapse. So rather than the leaflets just closing at the tips, there's about a 2 to 3 millimeters of overlap at the leaflet bodies, rather than just closing at the distal leaflet tips. This allows to have appropriate contact. So during systole, you get a good amount of coaptation and structural support of the mitral valve apparatus to prevent systolic regurgitation. So we can see there's the 2 to 3 millimeter overlap during systole, third zone of coaptation. Okay, now getting into mitral valve prolapse. So mitral valve prolapse is defined by systolic displacement of one or both of the mitral valve leaflets greater than or equal to 2 millimeters beyond the mitral annular plane into the left atrium. And so we can see on this image on the top right here, our mitral annular plane is depicted by the red line there. And we can see that both the anterior and posterior leaflets are being displaced by more than 2 millimeters into the left atrium. Now, this should be, on a transthoracic study, this should be identified on the parasternal long axis view, as the apical forward chamber view can often be misleading due to the saddle-shaped annulus as depicted in this diagram here, where especially in an apical forward chamber view where you may not be seeing the A2 and P2 scallops, that it may give the impression that the leaflets are being displaced beyond their insertion point, but they're not actually displaced beyond the annular plane. So it shouldn't be used to make a diagnosis of prolapse. And why we care about mitral valve prolapse is that it can lead to significant mitral regurgitation, with the classic appearance being an eccentric jet, with the general rule of thumb, the jet travels away from the prolapse segment. When we talk about grading of mitral valve prolapse, there's some older textbooks that have categorized the severity of prolapse based on the degree of displacement beyond the annular plane, with mild prolapse being 2 to 5 millimeters, moderate prolapse being 5 to 10 millimeters, and then severe being greater than 10 millimeters. However, the degree of mitral regurgitation is what's clinically more relevant for prognosis and management. And so therefore, the severity of mitral valve prolapse is often graded by the severity of the mitral regurgitation. As a general rule of thumb, though, the more severe the prolapse, the more likely the mitral regurgitation is going to be significant. We talk about epidemiology of mitral valve prolapse, so it affects about 2 to 3% of the general population, so maybe a bit more common than we may expect. There's a female predominance with a 3 to 1 female to male ratio in all comers. It is the most common cause of primary regurgitation in the Western world, and it's commonly associated with systemic connective tissue disorders and some genetic abnormalities, which we'll touch upon. Going into the pathophysiology and histopathology of mitral valve prolapse, so the most common cause of mitral valve prolapse is primary myxomatous degeneration and its most severe form called Barlow's disease, which we'll spend some time talking about. And the other main kind of etiology to discuss is something called fibroelastic deficiency. Other causes can be due to syndromic mitral valve prolapse or secondary to connective tissue diseases, such as Marfan syndrome, Loewy-Dietz syndrome, Ehlers-Danlos syndrome, Stickler syndrome, etc., with a longer list of other connective tissue diseases that can be implicated. And then there are some acquired mechanisms that are a bit more rare, which include infective endocarditis and closed chest trauma. Okay, now looking at myxomatous degeneration and the histopathology. So this is a cross-section of a mitral valve leaflet, with the normal layers of a mitral valve leaflet being the atrialis, the fibrosa, and the spongiosa. Now, when it comes to myxomatous degeneration, the main histopathologic finding is that you get significant expansion of this spongiosa layer with accumulation of proteoglycans and glycosaminoglycans. But this results in the classic kind of thick, bulky, and redundant leaflets that we classically see with myxomatous changes. We also get infiltration and replacement of the fibrosa segment, which results in disorganization and replacement of collagen, and therefore reduces the tensile strength, which gives us that kind of floppy appearance of the cords and the valve leaflets. And then lastly, we get elastin fragmentation, which contributes to the increased extensibility and floppiness of the valve. And so we can see these changes on this bottom slide here with classic Barlow's disease. Speaking of Barlow's disease, so Barlow's disease was first described by Dr. John Barlow with first publication in 1963 in the American Heart Journal. Dr. Barlow is a well-known cardiologist from South Africa who has really paved the way with what we know today about mitral valve prolapse. Characteristic findings of Barlow's disease are advanced myxomatous changes. So we see diffuse leaflet thickening, generally greater than 5 millimeters. There's excessive and redundant bulky tissue. We'll see billowing of the mitral valve leaflets, and I have some examples of what billowing looks like. And then classically, we see significant annular dilatation. Another way to describe Barlow's disease is classical mitral valve prolapse phenotype. And so I may use those words going forward when we're looking at some case examples. Classically, you'll have the mid-systolic click and mid-systolic mitral regurgitation that we're familiar with mitral valve prolapse. And it often presents a bit earlier in life, generally less than 60 years of age. Contrary, when it comes to fibroelastic deficiency, this is typically considered as non-classical mitral valve prolapse, and it's often attributed to accelerated aging process and impaired production of connective tissue that may be associated with syndromic connective tissue diseases, In contrast to Barlow's disease, it's characterized more by thin, smooth leaflets, although you may have mild thickening of the prolapse segments. There's often local or single segmental prolapse, with the P2 scallop being the most common scallop for prolapse. And there's normal or only mildly dilated mitral annulus, and they're more likely to have associated chordal rupture. They often present a little bit later in life, greater than 60 years of age. So I just want to share some cases of some mitral valve prolapse that I've been a part of during my past 2 weeks on elective here at St. Mike. So all of these cases that we're looking at are cases from St. Mike's. So this is a patient in his 80s with mitral valve prolapse. On the left here, you can see that both of the leaflets are traversing the annular plane into the left atrium. And this is what a billowing mitral valve looks like on transthoracic, where the leaflet tips stay above the annular plane, but you get this bulging of both leaflets across the annular plane and into the left atrium. And here we can see a quite eccentric jet of mitral regurgitation that is posteriorly directed. This is the same patient, but looking at a transesophageal echocardiogram, the mid-esophageal view. And here we can nicely see this billowing of the mitral valve leaflets, where, again, the leaflet tips are at the level of the annular plane, but are still pointing towards the left ventricle, with severe prolapse of both leaflets. In contrast to flail segments, so in a flail segment, both the leaflet body and the leaflet tips will cross the annular plane, with the leaflet tip pointing upwards toward the left atrium. So here on the left, these are transesophageal echocardiograms. So on the left, we have a mid-esophageal bicommissural view with an X-plane going through the medial P2 and A2 scallops, which gives us an orthogonal view. And then on the right-hand side here, we can see that there's a flail component of this posterior leaflet with a ruptured cord that's pointing up in towards the left atrium. And then when we put color Doppler on this, we can see that there's a significant amount of mitral regurgitation that's eccentrically directed, or eccentric and anteriorly directed. This is another example of more so non-classical mitral valve prolapse. And here we have a P3 flail leaflet. Again, on the left here, we can see that this posterior leaflet, there's a ruptured cord with the leaflet tip pointing towards the left atrium. And again, we're seeing significant eccentric mitral regurgitation. Looking at in 3D can help really confirm where the location of that prolapse is. So on a 3D view on a transesophageal echo, we can see we're looking at a short axis view of the mitral valve looking from the left atrium into the left ventricle. And so on the top here, we have our anterior leaflet, and the bottom we have our posterior leaflet. And then working from left to right, we have the A1, A2, A3 scallop, and then on the bottom, P1, P2, P3 scallop. And here we can see that there's a focal flail of the P3 scallop, really nicely shown here, with a quite eccentric mitral regurgitation when we put color Doppler on it. And just because I've had so many nice cases of mitral valve prolapse during my time spent here, I wanted to show one more case that shows a really nice example of a flail segment. Again, here, this is a transesophageal echo of a mid-esophageal four-chamber view. And we see that and this is at the level of the A2 and P2 scallops. And we can see that there's a focal segment of flail at the level of P2 with a ruptured cord pointing up and towards the left atrium with quite eccentric, significant mitral regurgitation. I know I've been talking about Barlow's disease and fibrolytic deficiency, or classical and non-classical mitral valve prolapse, as two distinct entities, but it is important to recognize that it really is on a spectrum. And so you can have something that may start as fibroelastic deficiency, and with further degeneration over time, accumulation of leaflet tissue, you can get that kind of thickening and myxomatous changes. So they aren't rather kind of completely distinct entities, but rather exist on a spectrum. Looking at some other features, echocardiographic features of mitral valve prolapse. So M mode can be quite helpful to make the diagnosis of mitral valve prolapse. Here on the left here is a normal M mode through the mitral valve leaflets, where normally in diastole we get the double hump, with the first hump being the early diastolic filling, and then the second hump being the atrial kick. When it comes to mitral valve prolapse, And looking at our normal, again, during systole, you should have a nice closure line of the mitral valve leaflets, and then again, they open up when diastole occurs again. When it comes to mitral valve prolapse, you get this closure line, but then you get something classically called systolic posterior motion or systolic buckling, where you get posterior translocation of the leaflets in kind of mid-systole. And then similarly, you can get systolic hammocking, where it's more so holosystolic, where you get displacement of that leaflet throughout systole, and it looks like a hammock appearance. And I have a picture of that on a following slide. Another finding that you can see is called multiple systolic echoes, where you see multiple parallel lines in sequence here, and this is due to the redundant thickened leaflet tissue. And this is just a nice example of systolic hammocking in mitral valve prolapse, where you can see this posterior leaflet has this kind of curved appearance in systole all the way until diastole occurs again. And if you have holosystolic hammocking and posterior excursion by more than 3 millimeters and systolic buckling greater than 3 millimeters, this has an 85% sensitivity and 99% specificity for diagnosis of mitral valve prolapse. Yeah. It is important to know that there is a role for multimodality imaging when it comes to mitral valve prolapse. So a transthoracic study is our first-line test. It's readily available, easy, more accessible. Is our first-line test to assist with making the diagnosis, assessing the valve morphology, and assessing the severity of mitral regurgitation and its hemodynamic consequence, specifically left ventricular dilatation and left ventricular systolic dysfunction. However, transesophageal echocardiography is very helpful, and is strongly recommended when TTE provides insufficient or discordant information, gives us a more detailed assessment of the mechanism of mitral regurgitation, its severity, and can be helpful for intervention planning. And then lastly, cardiac MRI can be quite helpful, as it can be used to assess LV function and volume and MR severity if there is discrepancy between the clinical assessment and echo. And it can also be helpful when you're looking for myocardial fibrosis by the means of late gadolinium enhancement, or LGE. And we'll talk more about this when we get into the arrhythmic side of mitral valve prolapse. So this comes from the 2020 AHA valve guidelines, where we have class 1 indication for a transesophageal echocardiogram to assess for severity of MR and mechanism of MR if there's insufficient information on transthoracic study, and then similarly the role of cardiac MRI if there's a clinical discrepancy. Okay, when it comes to estimating the MR severity with mitral valve prolapse, we do see some unique challenges. The first challenge being that mitral valve prolapse often leads to non-holosystolic mitral regurgitation. Usually the mitral regurgitation occurs when the prolapse is at its peak, and therefore you get mid-systolic mitral regurgitation. Classic methods that we use to quantify mitral regurgitation, including PISA and vena contracta width, often rely on a single frame measurement with the assumption that the MR is holosystolic. So if the MR does not occur until mid-systole, the PISA and vena contracta may overestimate the MR severity. However, we can somewhat get around this by using regurgitant volume, which uses the VTI, or volume time integral of the mitral regurgitation jet, which is more reflective of the duration of mitral regurgitation. Another challenge we get is the jets are often very eccentric, and you can get something called the Coanda effect. So the Coanda effect is where you have a very eccentric jet that wraps along the wall of the left atrium, and by doing so, it loses a lot of energy, and it can result in a less impressive appearance on color Doppler. Again, too, it's important to cover the entire receiving chamber when you're evaluating mitral regurgitation, especially when you have mitral valve prolapse, as you can easily miss a very eccentric jet if you're not covering the entire left atrium due to this Coanda effect. Again, additionally, continuous Doppler alignment is often difficult because the jets are so eccentric, and so malalignment may underestimate the true Doppler envelope and impair our estimation of severity. And then lastly, using the PISA method, PISA shells have the assumption that the shells are perfectly hemispheric, but when it comes to mitral valve prolapse, they may be non-hemispheric, which reduces its accuracy. And then lastly, there could be multiple jets often present, especially with Barlow's disease, which makes it quite challenging to grade the severity. When it comes to management of mitral valve prolapse, so quite reassuringly, the majority of all patients with mitral valve prolapse have a benign prognosis. They either have very minimal, trace, or mild mitral regurgitation. If there's evidence of mitral valve prolapse but no mitral regurgitation or any symptoms, the general recommendations are follow up with a clinical exam and echo about every 3 to 5 years. If there's any concomitant mitral regurgitation, an annual assessment and echo is often recommended. And if you have severe mitral regurgitation associated with symptoms or left ventricular dysfunction, surgical intervention is indicated, and generally follow the guidelines for all. It follows the same guidelines as we follow for primary mitral regurgitation, with mitral valve repair being the more effective way to treat, the more preferred way to treat mitral valve prolapse surgically. So briefly walking through this diagram that comes from the 2020 AHA valve guidelines, if you have severe primary mitral regurgitation, which is usually identified by the 4, 5, 6, 7 rule, so an ERO greater than 0.4 centimeters squared, regurgitant fraction greater than or equal to 50%, regurgitant volume greater than or equal to 60 milliliters, or vena contracta greater than or equal to 0.7 centimeters. If you have symptoms, and generally it's symptoms of heart failure, there's a class 1 indication for mitral valve surgery, with repair being the preferred method. If there's a high or prohibitive surgical risk, transcatheter edge-to-edge repair may be considered 2A recommendation. There's no symptoms due to the mitral regurgitation, but they have evidence of left ventricular systolic dysfunction defined by an EF of less than 60%, because in severe mitral regurgitation, you expect the ventricle to be hyperdynamic. Or you're seeing evidence of left ventricular dilatation, so that's an end systolic dimension of greater than or equal to 40 millimeters. Again, class 1 indication for surgery. Okay, getting into the kind of fun part of the talk too, talking about mitral annular disjunction. So mitral annular disjunction, my slides are out of order actually. So mitral annular disjunction is a gap between the ventricular myocardium and the mitral annulus. And so normally the mitral annulus is in close connection with the ventricular myocardium. And it kind of creates a continuity between those structures, which provides additional support to the mitral valve apparatus. However, when you have a gap between the ventricular myocardium and the mitral annulus here, this is called mitral annular disjunction, and it kind of disconnects the ventricular myocardium between the mitral valve annulus, which causes its own issues that we're going to talk about in a bit more detail. So looking at some echo features of mitral annular disjunction, the systolic disjunction gap is best seen on the posterior lateral wall of the peristernal long axis view. It's usually seen on this peristernal long axis view as the kind of anterior part of the mitral valve annulus is protected by the aortomitral continuity, so there's much more structure keeping it in place there. And as I mentioned, the mitral annulus functionally becomes decoupled from the left ventricle due to this disjunction gap. And the posterior portion of the mitral valve annulus moves more so with the left atrium in systole rather than the left ventricle. And this can result in systolic curling of the basal infralateral wall, which I have some examples of. So this is a nice example of mitral annular disjunction that was seen on a case here at St. Mike's Hospital, courtesy of Dr. Abdul, one of the echocardiography fellows here. So you can nicely see here in systole that we see that there's this gap between the leaflet insertion point and the ventricular myocardium. We can measure it here, and it measures to be about 6 millimeters. And here I have that systolic curling, where you can see that rather than just this posterior lateral wall thickening and moving into the kind of barrel of the left ventricle, we see it curling towards the left atrium. And that's because this mitral annulus is expanding and kind of moving with the left atrium, which curls it into the or curls the basal infralateral wall towards the left atrium. And this becomes relevant because it puts a lot of mechanical stress on the infralateral wall there, which causes myocardial injury and subsequent scar formation, which is what gives it its arrhythmic properties. Another feature, echocardiographic feature of mitral annular disjunction is something called the Pickelhaub sign. So The pickle hub is a helmet that was worn by the German soldiers in the 1800s, and it's characterized by its iconic spike on the top of the helmet. So the pickle hub sign is the abrupt systolic movement of the lateral annulus that can be seen on tissue Doppler assessment of the lateral annulus. It's greater than 16 centimeters per second. It's associated with a high risk of malignant ventricular arrhythmias and sudden cardiac death. And in this example here, we can see this tall systolic spike. And here it's reaching nearly 40 centimeters per second. So quite abrupt movement of that posterior lateral annulus.
So Chris, I guess you have to perform that on the apical three chamber.
I think you can perform it. I think you should perform it on the apical three chamber view, yes, because that's where you're really seeing that lateral annulus. Yeah. And the four chamber view, you could miss it. On this view here, this view here, we're seeing it on the apical three chamber view.
Which we don't routinely do.
So it's something to consider if you're thinking about mitral valve prolapse and mitral annular disjunction. Doing a tissue Doppler assessment on the apical three chamber view may be helpful. Another echo feature of mitral annular disjunction is the double hump on the left ventricular strain analysis. So you may see the kind of two humps that are depicted here, with the first hump being the normal early systolic shortening that we expect to see. And then you see a bit of a trough here, and that's due to this late systolic lengthening of the mitral annulus due to leaflet prolapse and annular expansion due to mitral annular disjunction. And that'll take you to the end of systole. However, post-systole, you've created some potential energy by that annular expansion and leaflet prolapse, and now you get a recoil effect in end of systole, which gives you another peak in early diastole or end of just after systole. Classically, you may see a double hump finding there. So how do we measure mitral annular disjunction and its implications? So it's measured between the posterior leaflet and left atrium insertion site and the adjacent basal infralateral wall. And it should be measured during systole. It's considered present if it's greater than or equal to 1 to 2 millimeters, depending on the source. However, it can be difficult to see on transthoracic, especially if it's very subtle. With true mitral annular disjunction, the disjunction is present in both systole and diastole, but is generally only seen in systole as you get that annular expansion as mentioned. The MED length of greater than 8.5 centimeters has been quoted to be associated with higher risk of malignant ventricular arrhythmias and sudden cardiac death.
That can't be 8.5 centimeters.
Oh, millimeters.
Sorry, that's yeah. Sorry, that's a typo there. Cardiac MRIs can also be helpful when assessing arrhythmic mitral valve prolapse and mitral annular disjunction. It's more sensitive than transthoracic echo to diagnose mitral annular disjunction. Again, at least greater than or equal to 1 millimeter of disjunction between the basal infralateral wall and posterior leaflet insertion into left atrial wall, with the greater the distance giving a higher arrhythmic risk. It can also be helpful to determine if there's presence of late gadolinium enhancement and localizing the late gadolinium enhancement to assess for kind of scar formation. And this scar formation seems to correlate well with origins of PVCs or ventricular arrhythmias, with the most common finding or locations being the mitral annulus, including the annular disjunction gap, the papillary muscles with the posterior medial being more affected than the anterolateral, and then the infralateral left ventricular wall. And this is a nice kind of small study that looked at patients with bileaflet mitral valve prolapse done by Chakrabarty et al. And mitral annular disjunction, who either had a high burden of PVCs or ventricular arrhythmias. And so they took these patients and performed PVC mapping with subsequent targeted ablation of where they found those signals. And as shown here, the most common sites that they found the voltage mapping showed was the mitral valve annulus, the inferior infralateral LV wall, and then the posterior medial papillary muscle up to 83% there. And so they ablated these sites after the mapping, and they found that there was significant reduction in PVC burden and no recurrence of VT episodes over a follow-up period of about 34 months. So it does show that the scar formation does seem to correlate from where these arrhythmias are coming from, and then kind of burning that tissue or altering that scar tissue can reduce the burden of PVCs and reduce the risk of ventricular arrhythmias. It's important to discuss about the concept of pseudomad as well. So In true MAD, as I mentioned, there is a true gap between the basal infralateral wall and the mitral annulus. However, if you have a severe prolapsing segment that is compressed against the left atrial wall, it may give the appearance that there is mitral annular disjunction, but it's really that this that prolapse segment is so severe that it's hugging the left atrial wall. So it gives the appearance of mitral annular disjunction, but the leaflet insertion is still at the that annulus is still in contact with the basal infralateral wall. It's important to recognize because the implications of pseudomad are not quite clear. So risk factors for malignant ventricular arrhythmias and sudden cardiac death in arrhythmic mitral valve prolapse. So significant features are bileaflet prolapse, the MAD length of greater than 8.5 millimeters, correct units there. You have the lateral mitral annulus S prime on the apical 3-chamber view of greater than 16 centimeters per second. That's our pickle hub sign. You have classic mitral valve prolapse with the severe myxomatous degeneration. Significant late gadolinium enhancement on cardiac MRI. And what significant means is still to be determined. If you have severe mitral regurgitation, and if you have hemodynamic consequences of mitral regurgitation, specifically LV to systolic dysfunction with an LVEF less than 50%. And so now the question is, what do we do for these patients in terms of, you've diagnosed a patient with mitral annular dysfunction or arrhythmic mitral valve prolapse. What's the best plan of action when we talk about screening and prevention of sudden cardiac death? So the answer to that question isn't entirely clear. There's a few papers that have developed some proposed algorithms. This first one on the left was published in 2025 in Nature. When patients with mitral valve prolapse who have ECG findings that are of higher risk, so T-wave inversions in the inferior leads or complex ventricular ectopy, and then greater than or equal to 3 echocardiographic features of high risk, including the mitral valve or the bileaflet prolapse, infralateral MAD length greater than 5 millimeters, what they quoted here. Systolic curling, EF less than or equal to 50%, or a pickle hub sign. They should have a cardiac MRI to assess for late gadolinium enhancement. If there is late gadolinium enhancement, they should have Holter ECG every 6 months. And if there's evidence of sustained VT, polymorphic NSVT, or VT or NSVT resulting in syncope, there should be a patient-informed kind of discussion about consideration for an ICD. I think the management becomes a little bit more clear if we're talking about secondary prevention ICDs. I think if you have someone who has a cardiac arrest from a ventricular arrhythmia or sustained ventricular arrhythmia, discussion may be a little bit easier. But really the question is, you have these patients with high burden of PVCs, complex PVCs, lots of NSVT, and some symptoms, where you're kind of really thinking still more about still a primary prevention device. The recommendations still aren't entirely clear. Whereas if you don't have that late gadolinium enhancement and you're asymptomatic, still getting Holter ECG every year can be reasonable because we know these patients are a bit higher risk. So monitoring for ventricular arrhythmias is important. On the right here is another algorithm that's quite similar. Again, starting from if you have mitral valve prolapse and symptomatic on the basis of palpitations or syncope, secondary to ventricular arrhythmias. Again, considering a cardiac MRI, and then if you made this diagnosis of arrhythmic mitral valve prolapse on the basis of ventricular arrhythmias correlating with symptoms, symptom control is also important to consider, so that could be considered with beta blockers or calcium channel blockers, and then second line being antiarrhythmic medications or catheter ablation if no response. And then again, prevention of sudden cardiac death, where ICD should be considered for secondary prevention, but also a discussion could be had for primary prevention purposes as well. Sorry if that's a little bit small to read there. Okay, and then coming to our key takeaways here. So what I want to leave with you today is that mitral valve prolapse is the most common cause of primary mitral regurgitation. It affects up to 2 to 3% of the general population. Diagnosis should be made on transthoracic in the peristernal lung axis view, and then multimodality imaging with transesophageal echo and cardiac MRI can be helpful to confirm the diagnosis and grade MR severity. I want you to be on the lookout for concomitant mitral annular degeneration. And then thinking about the risk factors for sudden cardiac death with arrhythmic mitral valve prolapse, including bileaflet prolapse, mitral annular disjunction length greater than 8.5 millimeters, the pickle hub sign, late gadolinium enhancement on cardiac MRI, severe mitral regurgitation, LVEF less than 50%, and then severe textomatous degeneration. And here are the references that I used to build this talk. And I'll open up the floor to any questions or further discussion.